thing that I've kind of tried to report on of women's health at midlife is, or starting also in your 60s as you begin kind of this aging process, as you're told, right? That's when, there's several questions in here about osteoporosis, and you're told that hormone replacement is helpful for that. Then everybody starts to worry about Alzheimer's and neurodegenerative disease, and how do they keep their brain intact, and maybe hormones are good or not good for their brain health. And then there's autoimmune diseases, and then there's a kind of, it seems to be like a perfect storm when you're about 65, that all these things start happening. So for so many women, I think, have asked questions here, is it too late for me to start doing a lot of these things? I'm in my early 60s, and for the last 20 years, I didn't pay attention because I was feeling A-okay, pretty good, or not so great, or I didn't have any time. What do I do now? And I haven't done anything. There's a lot of women like that out there, and so there's a lot of women who just didn't have time. They didn't have insurance. They went in and out of jobs. They became widowed. They lost their insurance. So, what is the first step you would say to taking control of your health today? You're in that 40 to 60 and then 60 beyond. Lisa?
Well, right. So I think I would encourage women between 40 and 60 really to have a good gynecologist that they're seeing and their internist, and really to advocate for themselves, to ask these questions specifically about, I have a family history of breast cancer. I'm told that my breasts are dense. My lipids are a little bit up now. I'm gaining weight. Have conversations about what all of these things put you at risk for in the future, and really talk to someone that knows about these things, because that is, in my opinion, the most critical time between 40 and 60, where I, as a doctor, can make the most impact on a woman's life, right? If I can get her to maintain her body weight, exercising, not drinking too much alcohol, getting enough sleep, doing all of the lifestyle things, and then we as the clinician assessing all of these other risks, I can actually impact her risk of developing cancer and future heart disease and diabetes long-term. When a woman is older, so to your point, 65, you haven't done anything between 40 and 65. Now you're not feeling great and you show up in the doctor's office. The first thing I would say is no, it doesn't mean that that's the end of the road and it's too late. The discussion about taking hormone therapy may be different at 65. If you've gone from 50 to 65 without taking hormone therapy, that may not be something that I would recommend. And we would never prescribe it then as an anti-aging therapy. I see a lot of that happening, but I would never want a 65-year-old woman to start hormone therapy thinking that this is the fountain of youth, right? We've gotten really way beyond that. But there are lots of things that we should be doing. And again, it goes back to assessing risk factors for future disease and doing everything that we can to optimize health and wellness at that time. And a lot of it is lifestyle. We have to focus more in medicine on lifestyle, nutrition, diet, exercise, stress management, all of these things, because we know they affect disease development.
Well, Stephanie, let me ask you, I thought this was kind of interesting from Diane, and a few other people said that a lot of these weight loss drugs are marketed to women. A lot of cosmetic procedures marketed to women, Botox, right? Do we have any idea what any of these things, be it Botox, be it, these weight loss drugs that are also done through shots, have any effect on our overall health? And they seem to be very marketed to women.
Well, here's the more disturbing fact. So let's take semaglutide, Ozempic. I actually went back and looked at the original trials that where those drugs were tested, and big journals, big journals like New England Journal of Medicine, JAMA, that kind of thing, looked at the trials. They report the number of men and the number of women in the trial, but they do not do the analysis by sex. So we don't know if the drugs work better in women, the same in women, or worse than women. And I actually contacted the authors myself to say, can you do the analysis by sex? And that for a number of reasons, subgroup analysis, blah, 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 all kinds of excuses, but they could not, did not, and have not done it. So we still don't have sex-based data on these weight loss drugs. And it's something that we desperately need. So when you get down to, is there a difference in men and women? We still don't know. Does it impact menopause symptoms? It might, because we do know that weight loss impacts menopause symptoms for some women. So would it be more so with these drugs? We just don't know. I can't really speak to the Botox question, but maybe one of my colleagues can.
Yeah,
I think the big thing about the semaglutide is just we don't have long-term data. And now that so many people are using it and it's out there in all different forms, and this is big business, there's a lot of compounding of it now and a lot of use in patients off-label that don't actually meet the criteria to be using it. And we're starting to see all kinds of other things happening related to it post-marketing that, again, because the trial that led to approval was 52 weeks, right? So we don't have 5-year, 10-year data. And I can tell you in practice, we're seeing stuff. And there's now reports about mood impact cases of depression that have been triggered by these medications. And certainly I've had one patient so far with pancreatitis, right? These aren't benign drugs and we don't have a lot of long-term data. So in my opinion, it should be a very guideline driven on who's using these. And really under a supervised physician that knows what they're doing.
And it's not just for 10 pounds of weight loss to get into a dress.
Yeah, because a lot of people here said, that they had weight gain from menopause, and we're asking about that. Christy just threw up a question here about progesterone that we haven't talked about that. That's kind of included, I would think, in the hormone therapy conversation, estrogen, progesterone. Is it not, or should we address that separate out?
Sure.
Sharon.
Sure. If you have an intact uterus, and that just means for every person who has a uterus and has not had a hysterectomy, yes, when you take estrogen, you should also take a progestin or a micronized progesterone. It appears that there's a lot of conversation out there about whether synthetic progestins and whether synthetic hormones are better than natural or micronized progesterone. And one of the things I'd like to sort of clarify is that all progesterones are synthetic because they're man-made. There's no natural source progesterone. So it appears that for some women, the micronized progesterone might have less of an effect on breast density. It may have less of an effect on just the development of breast cancer. Some studies show that. But again, we don't want to get to a point where we're painting ourselves into a corner, because all of the data that we have out there, and some of which is quite encouraging, the decrease in the risk of colon cancer with hormone therapy that has estrogen and medroxyprogesterone. It actually is, we have more data on synthetic progestins than we do on natural progesterone. So the notion that you are taking a synthetic should not be something that someone should be afraid of, or to be fearful that if you are taking a synthetic progestin, that you are doing yourself more harm. I think that you have to take a progestin. One may be less good than the other, but neither of them is bad, because there are some people who do not tolerate natural progesterone. And if you don't tolerate it, I'd rather you have a synthetic, or, well, they're all synthetic, but one of the progestins, rather than taking nothing. And I think that we've had a lot of experience with these progestins because these are the components that are in birth control pills. And we have a lot of long-term data just in premenopausal women with these progestins. But I don't want women to think, sometimes there are marketing terms. It depends on which one to choose would be, which one do you tolerate, and what is our treatment goal at the end of it.